Good afternoon. My name is Felicia Jackson, and my presentation today is going to be walking in the shoes of domestic violence clients or patients. Domestic violence is seen in the male population as well as the female population, as well as with gay and lesbian couples, as well as straight couples. So in our clinic, we usually use personal safety assessment on each and every client that comes in, and this is what we use to screen for domestic violence. As a public health clinic, we're required to screen the male and the females. The magnitude of the problem. The lifetime prevalence of having been raped and or physically assaulted by a current or former partner. In women, the percentage is 24.8%. In men, it's 7.6%. Usually we think of abusive people as being only females, but it also is in the male population. What we know, 1 in 4 women or 1 in 5 teen girls are reporting experiencing physical and sexual violence by a partner. Women who talk to their healthcare provider about the abuse are 4 times more likely to use an intervention, 206 times more likely to exit the abusive relationship. So that's why it's so important that we as healthcare providers screen and screen well our patients. Terms to know. Victim or survivor is the person on whom the violence is inflicted. The perpetrator is the person who inflicts the violence. Domestic violence. A pattern of behaviors by one partner to create a current of terror in the effort to maintain power and control in an intimate relationship. This relationship could be a marriage, it could be dating, it could be in any family, and also in cohabitation. There are 5 types of domestic violence: psychological abuse, physical violence, sexual violence, threats of violence, and economic coercion. Psychological abuse is when one partner wears down the other's self-worth or self-esteem. This includes controlling what his or her partner can do, manipulating information from his or her partner, isolating the partner from friends and family, electronic aggression, Facebook, cultural, spiritual, social stereotyping, and stalking. Physical violence includes kicking, pinching, pushing, hitting, shoving, strangulation, throwing, shaking, grabbing, all of those physical things. Sexual violence. Sexual violence is any sexual act that is forced against someone's will. There are 4 categories. The first one is a completed act of penetration, or any penetration of the vagina, the anus, or other orifice by any object. Attempted act of penetration, abusive sexual contact, which is intentional touching, and non-contact sexual abuse, which includes voyeurism, exhibitionism, verbal or behavioral sexual harassment, threats of sexual violence, taking and posting sexual pictures. The meaning of consent is present when all partners have agreed to sexual activity without the presence of force, fraud, lies, or coercion. To give fully informed consent, you must have all of the information, the power to make a choice, the power to say no, and the power to change your mind. Threats of violence. Threats of physical or sexual violence include the use of words, gestures, weapons, and other means to communicate the intent or cause harm. Economic coercion is when one partner limits or controls the other's access to resources. Examples of this is not allowing the partner to go to school, not allowing the partner access to money or to the bank accounts, giving the partner a fixed allowance, forcing the partner to work 1 or multiple jobs, ruining the partner's credit, and not allowing the partner to access legal or medical resources. The power of and control. This is a wheel that we often use, and it includes using intimidation, emotional abuse, using isolation, denying and blaming, using the children, using the male privilege, as well as we discussed before, the economic abuse and the coercion and the threats. The medical consequences of physical abuse from domestic violence could be the rupture of personal, emotional, and sexual boundaries, inability to maintain personal relationships, engaging in risky sexual behavior, unintended pregnancies, sexually transmitted infections, chronic abdominal pain, chronic pelvic pain, chronic headaches, depression, anxiety, suicide attempts, preterm labor, vaginal bleeding, blood trauma, and sleep disturbances. Barriers to disclosing. And these barriers are created by medical personnel, us nurses. We as medical personnel can also, be a barrier to a patient that's disclosing if they're being abused. And some of these including if we're violating confidence, interviewing the patient in front of family members, telling colleagues issues discussed in confidence without the consent of the patient, calling the police without the consent of the patient. We know all of those are no-nos here. Trivializing and minimizing the abuse, not taking the danger that the patient feels seriously, expecting a tolerance because of the number of years that the client has been in the relationship, blaming the victim, asking what did they do to provoke the abuse, focusing on the problem and asking why don't you leave? Why do you put up with it? Or him? Or why do you allow him to do that to you? Not respecting the autonomy of the client, prescribing divorce, sedative medications, couple counseling, or the involvement of the police enforcement. Ignoring the need for safety, failing to recognize the sense of danger to the patient, normalizing or victimization, failing to respond to the patient's disclosure of abuse. The patient may experience barriers to leaving. They could think they're in love, they could be confused, believe that they can change the partner, which is quite often what abusive clients do feel. Promises, denial, shame, or guilt is quite common. Fear of retaliation or harm, fear of being alone, loss of independence, peer, family, and cultural pressure, distrust of the police, fear of being outed, lack of information and resources is where we are very, very important. Lack of legal status, and we see that quite often in public health. Here we have a lot of undocumented clients, and they feel that if they disclose that they are being abused, they will be deported. Also, low self-esteem. This is the radar, and we call this the RADAR is a domestic violence intervention. The R stands for routine screening, which we do with the safety assessment. A means asking direct questions. D, documentation of our findings is very important. A is access to patient safety, and R is review options and then refer to the appropriate agency so that the patient can receive the help that they need. Crisis intervention. We must make sure that the patient knows that the violence was not their fault. Empathetic listening. We need to ask open-ended questions in a non-judgmental way. Paraphrase our responses. Validate the client's feelings. Safety plan. Advocates provide options, not advice. That is the end of my presentation. Thank you for listening.